Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, kidney transplant immunosuppression. Kidney transplantation involves a donor kidney being introduced into the recipient, and the foreign antigens, most often HLA antigens on the donor kidney, can be recognized by the patient's immune system and result in rejection of the graft. Although HLA compatibility may decrease the risk of rejection, genetic HLA compatibility is not necessary for kidney transplantation to occur. What is necessary is, first, the absence of preformed antibody that is assessed by cross-matching, and in most cases, secondly, ABL blood type compatibility. For an overview of transplant immunology, including these topics, check out the other video at this channel and the article at bcnephro.com. I'll have links to both in the description below. However, in almost all cases of kidney transplantation, immunosuppression is required. This immunosuppression typically addresses lymphocytes, T lymphocytes, which are involved in cellular immunity and therefore cellular mediated rejection, and also to some degree B lymphocytes, which are involved in humoral immunity and can lead to antibody mediated rejection. Interleukin-2 is a cytokine that's very important in the proliferation of T lymphocytes, and this is often a target of immunosuppression. Now let's get into it. Immunosuppression involves induction at the time of transplant when the risk of rejection is highest, and maintenance. Induction immunosuppression is typically one of two agents. The most common is something called thymoglobulin. Thymoglobulin is also referred to as RATG, rapid antithymocyte globulin. This is a polyclonal T-cell depleting antibody. It's created by taking human thymocytes and incubating them with rabbits to get the polyclonal antibody. Some of the side effects of this include leukopenia and thrombocytopenia. The other induction agent that is sometimes used is something called basiliximab. Now, basiliximab is an antibody against CD25, which is on the interleukin-2 receptor on T cells, and therefore it prevents interleukin-2 mediated T cell activation. Moving on to maintenance immunosuppression, this is also started at the time of transplant. In higher doses, when the immunologic risk of rejection is lessened, the doses are decreased. However, in almost all cases, immunosuppression needs to be continued indefinitely for the life of the transplant. Now, there's 5 agents we're going to talk about. The most important cornerstone is something called calcineurin inhibitors. The most common one is tacrolimus. Calcineurin is involved in the transcription of interleukin-2, so by blocking this, by inhibiting this, the production of interleukin-2 is impaired. The next class of drugs is antimetabolites. The most commonly seen in transplantation is mycophenolate, either mycophenolate mofetil or enteric-coated mycophenolic acid. This impairs nucleotide synthesis and therefore affects the cell cycle and production of both T and B lymphocytes. The third drug that's most commonly used is glucocorticoids, often a low dose of prednisone. Prednisone is nonspecific and affects the immune system in multiple different ways. The fourth class of drugs is something called mTOR, mammalian targeted rapamycin inhibitors. The most common is something called sirolimus. Sirolimus also impairs cell cycle proliferation and therefore the production of lymphocytes. And the last is something called belatacept. Belatacept is a co-stimulatory blocker and blocks the co-stimulatory signal for T cell activation. Of these 5 immunosuppression drugs, most commonly 3 of the drugs are used. Calcineurin inhibitor, most commonly tacrolimus, along with an antimetabolite, most commonly mycophenolate, either mycophenolate mofetil or enteric-coated mycophenolic acid, along with glucocorticoids, which typically ends up being a low dose of prednisone. There are some centers that use a 2-drug regimen, the calcineurin inhibitor tacrolimus and the antimetabolite mycophenolate. The other 2 drugs are associated with a higher risk of rejection and are only used if there is other contraindications or reasons why one of the more commonly used drugs cannot be used. Belatacept can be used in place of a calcineurin inhibitor, along with mycophenolate with or without steroids. Belatacept is an intravenous drug that's given periodically, such as once a month. The sirolimus mTOR inhibitor also can be used in lieu of either a calcineurin inhibitor or the antimetabolite if there is a contraindication. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Let me know in the comments below your experience or questions about immunosuppression for kidney transplant. And until next time.